Dear participants, hello again. We can continue in the second part of today's event entitled Non-Alcoholic Fatty Liver Disease Management as Precondition to Prevent HCC. The first speaker is from Croatia, again. He is head of Department of Gastroenterology, Hepatology and Clinical Nutrition, University Hospital Dubrava, Professor Ivica Grgurević. Professor Grgurević will talk about NASH natural course.
Thank you very much for introduction, and I would like to thank Mrs. Tatjana Reić for invitation and to Hepatos Association for organizing this important meeting. And my topic today is natural history of non-alcoholic fatty liver disease. Very important topic, very important disease. Sorry. Okay, this is my talk outline. I will start with epidemiology of non-alcoholic fatty liver disease, then follow with the clinical outcomes, impact of severity of liver damage, then switch to progression of liver fibrosis in FLD, and conclude with some lessons for clinical practice. So first, the definition. When we talk about non-alcoholic fatty liver disease, these are key histological features of this entity. So to define fatty liver, we have to see at least 5% of fatty transformed hepatocytes per liver slide, defining steatosis here. Okay, then we have some features of damage to hepatocytes in ballooning of hepatocytes and lobar inflammation. So all these features are important to define the other entity within this NAFLD. It is NASH, or presence of destruction and inflammation of liver within fatty liver. And finally, a specific category is presence of fibrosis or scarring of the liver as the consequence of these destructive processes taking place in the fatty liver. These are the data about the prevalence of non-alcoholic fatty liver in Europe. And as you can see, about median prevalence in Europe is about 25-26%, and pretty similar numbers can be seen in other countries in the world, maybe a little bit more in United States. And it is important to notice that the prevalence of non-alcoholic fatty liver goes hand by hand with prevalence and epidemiological trends in overweight and obesity, positioning Croatia in the middle among the European countries, with about 60% of people in Croatia being overweight and about 25% obese, so body mass index more than 30, which are pretty worrisome figures. And this is one of our papers, one of our research published recently about the prevalence of fatty liver, non-alcoholic fatty liver in our outpatients coming to our department, outpatient ultrasound department. As you can see, as you can see, the median body mass index of our outpatients was 27, so mainly overweight patients, with 71.5% being with body mass index more than 25. And liver steatosis by ultrasound was detected in almost 50% of patients. Non-alcoholic fatty liver is becoming the leading cause of liver transplantation, and starting from 2015 in the United States, it surpassed hepatitis C as the indication for liver transplantation, with very clear trends showing increase in incidence of liver transplantation due to non-alcoholic fatty liver disease, as opposed to decreasing incidence of liver transplantation for hepatitis C. So this is prevalent disease, and now we are interested to understand which are the clinical outcomes in patients with non-alcoholic fatty liver disease. And this is a study coming from Sweden. They have very good epidemiological studies, group from Matthias Ekstedt, published in 2015, showing that overall survival of patients with non-alcoholic fatty liver disease is decreased in comparison to general population. So about 30% increased risk of dying as compared to general population. The main causes of death in patients with non-alcoholic fatty liver disease are cardiovascular diseases, non-hepatic malignancies, and then on the third place, liver-related causes of death. So more extra hepatic causes of death as compared to liver causes of death. In terms of morbidity and mortality in NAFLD, the higher mortality was associated or is associated with the older age, with deranged glucose metabolism, with the presence of cirrhosis and male sex. When we talk about liver-specific features which could be connected to more higher risk of morbidity and mortality. And if we focus on two most advanced stages of liver fibrosis, so F3 fibrosis, meaning advanced fibrosis, bridging fibrosis, or F4 fibrosis or cirrhosis, it is very interesting to note that patients with F3 fibrosis had more vascular events and non-hepatic malignancies, whereas patients with F4 fibrosis have more liver-related complication, meaning decompensation and hepatocellular carcinoma. So clearly different epidemiology of causes leading to death and complications in this population. Talking about the severity of liver damage and its impact on the course of liver disease, we know that although there is very high prevalence of NAFLD in general population, about 20 to 30%, as we already mentioned. Minority of patients develop non-alcoholic steatohepatitis and fibrosis, leading finally to cirrhosis, to decompensations, and hepatocellular carcinoma. And this is one of the classical studies coming from the famous Olmsted County in Minnesota, describing the natural history of NAFLD. So in their cohort of 420 NAFLD patients from general populations who were followed for about 8 years, cirrhosis prevalence was only 5%, with 2% at the initial presentation, plus 3% during the follow-up. Cirrhosis-related complications developed in about 3% of patients, and liver-related death occurred in 1.7 patients. So, in contrast to very high prevalence of NAFLD, the prevalence of final complications or final adverse outcomes is not that big. In terms of characteristics or features of liver disease as predictors of adverse outcomes, this is again a study coming from Sweden, showing that only patients with F3 and F4 fibrosis had deranged outcome, deranged survival, so worse survival, as compared to patients with lower stages of fibrosis, so F0 to 2, and in this later category, the survival was comparable with patients with people from general population. So only patients with F3 and F4 fibrosis had adverse outcome during the follow-up, and here we see that it was a very long follow-up of 26.4 years. So it is important to register, to see, to find the patients with advanced fibrosis among patients with NAFLD. And this is another very famous study coming from Paul Angulo group from United States, but this was a multicentric and multinational study with 619 patients all having liver biopsy, which demonstrated that fibrosis is the most important histological parameter defining or predicting the outcome of these patients, because if patients had fibrosis, then the survival was diminished as compared to patients who didn't have fibrosis, and the outcome was not influenced by the presence of necroinflammation, so NASH was not important predictive factor, only fibrosis, the stage of liver fibrosis was important factor for survival. This is pretty busy slide coming from this study again, showing that for overall mortality, risk factors for overall mortality in this group of patients were in higher fibrosis stage, higher age, older age, presence of diabetes, presence of current smoking, with protective role of statin use in this population, so overall mortality. However, if we focus only on liver-related mortality, then only fibrosis stage was important factor for defining the adverse outcome. So also it is important to understand which patient and which proportion of patient will progress in liver fibrosis in NAFLD, and these are results from one of famous meta-analysis performed over 11 studies that included 411 patients with paired liver biopsies. At the end of follow-up, about 36% of patients progressed in fibrosis. But what is important from this study, again, is that both patients with blend steatosis, so non-alcoholic fatty liver without steatohepatitis, as well as the patients with non-alcoholic steatohepatitis progress with almost similar, almost same proportion. And the annual fibrosis progression rate was higher, was faster in patients having NASH. So at the beginning, it is both blend steatosis and non-alcoholic steatohepatitis can progress. However, patients with non-alcoholic steatohepatitis finally progress faster as compared to the other category. And the factors from this meta-analysis that turned out to be associated with progressive fibrosis were hypertension and low AST-ALT ratio. The other study coming from Sweden, again, Hannes Hangström published this study in Journal Hepatology 2017, came to a little bit different figures, showing that roughly 7% of patients with NAFLD progressed during the follow-up period. And they also calculated the time to development of severe liver disease, and severe was defined as the presence of cirrhosis, liver decompensation, or HCC. So first 10% of patients from each fibrosis category, the time to develop this progressive liver disease was 22 to 26 years in patients with low fibrosis stage, 9.3 years in F2 fibrosis, and 2.3 years in patients with F3 fibrosis. Also, we know there are some genetic factors which are associated to adverse outcomes, to increased development of liver fibrosis and other complications. So PNPLA3 polymorphisms, gene polymorphisms, then transmembrane 6 superfamily member 2 polymorphism, glucokinase receptor. However, all these genetic polymorphisms are associated with the worse outcome, but only some genetic variants of hydroxysteroid 17 beta dehydrogenase act protective in this population of patients. There are some factors during the follow-up that are associated with progression in liver disease, so increase of ALT levels, AST levels, weight gain more than 5 kilos, more development of insulin resistance, more fatty infiltration in the liver, presence of diabetes, and higher FIB-4 score during the follow-up. So by this I'm coming to conclusions. First, NAFLD patients have increased overall and liver-related mortality compared to general population. Patients with more advanced liver histology, diabetics, older, and smokers have increased risk of death. Among histology features, fibrosis is the only one independently and significantly associated with both overall and liver-related mortality risk, and there is importance of genetic background. So in clinical practice, patients at risk for NAFLD should be evaluated for the presence of fibrosis, and our target should be patients with F3 and F4 fibrosis, because these patients have highest risk of morbidity and mortality. Patients with F0 to 2 should be re-evaluated for fibrosis in 3 to 4 years in order to catch the proportion of patients which are progressing in fibrosis. And if no worsening occurs after 3 to 4 years, then we can switch to follow-up every 5 to 7 years. And I would like to finish with this picture from my homeland, showing one olive tree, which is 1,500 years old. And olive is like a synonym for longevity and good health. So thank you very much for your attention.
Thank you very much to Professor Grgurevich. You're fast and furious, and I hope we were curious. So we are continue with our Croatian team from Department of Gastroenterology and Hepatology, University Hospital Center Sisters of Mercy. Came specialist Dr. Lucia Virovic-Jukic, and topic is impact of liver diseases on public health burden.
Thank you very much. I would like to thank the organizer for this very important meeting and for invitation to participate. I will talk about the influence and the impact of liver diseases on public health burden. Now, I'm not a public health doctor, I'm not an epidemiologist, I'm a clinician, a gastroenterologist, and a hepatologist, so I will speak from this perspective, from the perspective of clinicians. I will talk about this topic globally, but also about our local situation. So, liver diseases today, I think, represent a major and sometimes neglected public health problem. The problem with liver diseases is that they are very often silent. Patients have no symptoms until the end-stage liver disease develops. So they're very often unrecognized and undiagnosed. So current worldwide estimations are that around 840 million people have chronic liver diseases, and possibly these numbers are even higher. An estimated mortality rate is 2 million deaths per year, around 1 million from cirrhosis and another million from acute hepatitis, acute liver failure, and cancer. If we compare these numbers to the prevalence of diabetes, pulmonary diseases, cardiovascular, and other chronic diseases, we see that these numbers are equally high or even higher, and yet these diseases are very often neglected and not so much publicly advertised and not so much outspoken. The estimated worldwide prevalence of chronic hepatitis B is around 3.6%, with range from 0.5% in developed European countries to more than 8% in some parts of Africa. Similarly, chronic hepatitis C is around 2.5% globally, with also significant regional differences. But what is very important to stress is the prevalence of alcoholic liver disease, which is much higher. It is globally around 8.5%, and the highest prevalence is in Europe and USA, with some countries from Central and Eastern Europe having even higher rates of alcoholic liver disease. When we talk about chronic liver diseases, we have to be aware that every liver disease, no matter of the causative agent, has different stages where the disease progresses from inflammation, steatosis, to the development of fibrosis, cirrhosis, and to development of liver cancer. Whether it be chronic hepatitis C, where it takes years from the point where an individual is infected with hepatitis, the virus, to develop chronic hepatitis, cirrhosis, and end-stage liver disease with hepatocellular carcinoma. The similar situation is with alcoholic liver disease, and a similar situation we also have with non-alcoholic fatty liver disease. So it takes time from healthy liver to develop steatosis, steatohepatitis, fibrosis, cirrhosis, and hepatocellular carcinoma. Of course, we have to mention that sometimes hepatocellular carcinoma can develop without the development of cirrhosis, so we can sometimes skip one of these stages. However, all these diseases develop with time, so it's not an instant problem that we're facing with. When we talk about chronic liver disease-related morbidity and mortality, it is somehow estimated that chronic liver disease and cirrhosis induce cirrhosis in more than 600 patients per year, with a prevalence from 4.5 to 9.5 worldwide. And this is also probably underestimated, as already mentioned, since most patients remain asymptomatic and undiagnosed. If we consider that around 1/4 to 1/5 of patients develop decompensation, we come to the number of around 150,000 patients per year. Chronic liver diseases are the 14th cause of death in adults globally, the 10th in the developed countries, and the 4th in Central Europe. We'll come to the situation in Croatia in just a few moments. We're somewhere in between these numbers. And we also have to mention the growing incidence of hepatocellular carcinoma, with more than 500,000 cases per year around the world, most of them in Eastern Asia and Sub-Saharan Africa. But HCC is also responsible for around 49,000 deaths per year in Europe only. When we talk about the situation in Croatia, we can see that chronic liver diseases are the 10th most common cause of death for both sexes, and 8th most common cause of death for males. However, this is only regarding the fibrosis and cirrhosis. If we add hepatocellular carcinoma, chronic liver diseases would rank much higher, somewhere around the 5th or 6th place. So we are also dealing a situation where chronic liver diseases are a very common cause of death. In Europe, chronic liver diseases are responsible for around 29 million people suffer from chronic liver diseases, and they're responsible for 107,000 deaths per year. Around 5,500 liver transplantations are performed in Europe every day. Now, since this is the session about non-alcoholic fatty liver disease, I prepared some slides about the epidemiology of non-alcoholic fatty liver disease. However, we already heard some data. I would like to stress just that NAFLD is really one of the most common causes worldwide. It is, of course, more common in some parts of the world. Different studies and different estimations are known. We usually say that between 20 and 35% of adults are affected. The epidemiology and the epidemics of non-alcoholic fatty liver disease parallels the epidemic of metabolic syndrome, meaning the presence of diabetes and obesity. But it can also be present in around 7% of normal weight individuals. So even the people with no obvious metabolic syndrome are at risk of developing non-alcoholic fatty liver disease. So this slide represents that NAFLD really is a global problem. It is present everywhere around the world, with highest prevalence in South American and Middle East countries. It is very difficult to estimate the global prevalence in the general population, since liver biopsy is really not a convenient method for the diagnosis in the healthy or general population. These estimates that I said are based on the ultrasound examinations, where we come to these numbers according to study between 17 and 46%. Some studies used aminotransferases to detect NAFLD. However, these numbers are much lower because aminotransferases are often normal in non-alcoholic fatty liver disease. NASH is less prevalent, and it is estimated that around 3 to 5% of adult population is affected. The situation in Croatia is similar to the world situation. We have over 50% of people in Croatia who are overweight, and over 20% of people are obese. And we know that NAFLD is particularly prevalent in these risk groups, patients with obesity, with diabetes, patients with dyslipidemia, and other components of the metabolic syndrome. Now, we mentioned that chronic liver diseases, which are cured by liver transplantation in a number of cases, are performed more than 5,000 per year in Europe. The most common indication is liver cirrhosis, and the second one is liver cancer. What can also be seen is that the etiology of cirrhosis is less related to virus, and still we have a very prevalent alcoholic liver disease. The data for Croatia are shown here. These are the data from our largest transplant center, University Hospital Merkur, where we can see a comparison of two periods, and we can see that liver cirrhosis related to alcoholic liver disease still remains the leading cause for liver transplantation. However, we can see a large increase in the HCC in cancer-related liver transplantation. So HCC is becoming the fastest growing indication for liver transplantation. This HCC is related to different causes of chronic liver disease and cirrhosis, whether it be HCV or NAFLD or NASH cirrhosis. Now, when we talk about the money and the cost of chronic liver diseases, the costs are really high, but very difficult to estimate because of lack of data. I managed to find some older data for USA. We can see that we talk about the figures that are within tens of thousands of dollars and hundreds of thousands of dollars, depending on the disease and the stage of the disease. What is very important from my clinical point of view is that we always have to keep in mind that liver inflammation is the main mechanism of progression of liver disease. So necroinflammation induces the progression of fibrosis to cirrhosis and development of hepatocellular carcinoma. We have to bear in mind that it takes years for this process to develop, so we have a lot of time to intervene. We have to recognize patients suffering from chronic liver diseases when they are not aware of this situation. We have several options for estimation of fibrosis and inflammation, and of course they're based on non-invasive methods, meaning serological tests and imaging techniques, instead of invasive methods like liver biopsy, which are not acceptable. So we need to timely recognize these patients in order to treat them. So to conclude this talk, I would say that we have to keep in mind that a large proportion of chronic liver diseases can be cured, like chronic hepatitis C, or where we have drugs today that cure almost 100% of patients. A number of diseases can be prevented by vaccination and treated, like chronic hepatitis B, and others can be treated by implementation of lifestyle modifications. This pertains to alcoholic liver disease and non-alcoholic fatty liver disease. Timely diagnosis and intervention are necessary for the best outcomes, and yet chronic liver diseases are often neglected as public health problem. This relates to viral hepatitis in some part of Asia, Africa, and to alcoholic and non-alcoholic fatty liver disease in Western country. So urgent actions are needed for the prevention, the diagnosis, management, and treatment of chronic liver diseases. So in order to achieve this goal, we need large-scale screening. And of course, public awareness and participation by healthcare systems and authorities are required to reach this goal. I'm very proud to say that the Croatian Society of Gastroenterology has recognized the problem of chronic liver diseases. It has started a number of public campaigns through education, through television, newspapers, online resources. We also are involved in the screening of patients, and we have very good cooperation with Hepatos. I hope that we're all satisfied with our efforts, although much more needs to be done, of course. And we have also started a number of educational activities for our doctors. The Croatian Society of Gastroenterologists has recently established an educational platform, and not by chance, the first two modules and the first two educations are regarding chronic liver diseases. The first one is already active. It is entitled From Insulin Resistance and Non-Alcoholic Fatty Liver Disease to Liver Cancer, and we're expecting very soon to finish the other one, and this is the multidisciplinary approach to the treatment of HCC. Except from this online education, a number of courses are organized by our members, hepatologists from our hepatology centers, where primary care physicians are educated how to timely recognize chronic liver disease patients and how to intervene. So this is our new educational model, and I would like to invite everyone to have a look at it. And with this, I would like to thank you for your time. Thank you.
Thank you very much, Dr. Lucia Virovic-Jukic from Croatia. From Croatia, we are going to Portugal, to Vice President of United European Gastroenterology. Dr. Helena Cortes Pinto will talk about current and future fatty liver diagnosis and treatment possibilities.
Good afternoon, dear colleagues. It is a great pleasure to be discussing with you the current and the future of fatty liver diagnosis and treatment possibilities in this very high-level event held under the official umbrella of the Croatian presidency of the Council of the European Union. I will now start sharing my screen. And as you can see here, so this is the topic of my talk today. And these are my disclosures. So when talking about NAFLD, NAFLD is a large spectrum of disease that can present with only fatty liver, with either pure steatosis or steatosis and mild globular infiltration, or this may progress to non-alcoholic steatohepatitis with either an early F0, F1 fibrosis or a more advanced fibrotic phase, F2, F3, that can culminate in cirrhosis or F4. Either way, liver cancer or HCC can appear either through the cirrhotic phase or even in the non-cirrhotic phase, what's something that is not very usual in the progression of liver diseases, where usually HCC appears only in the fibrotic phase. Interestingly, this concept of NAFLD has recently broadened with suggestion for a change on the nomenclature from NAFLD to MAFLD, and MAFLD meaning metabolic associated fatty liver disease. And in fact, there is a large heterogeneity in MAFLD. It has different disease subtypes. It has a variable natural history. It has an inter-individual variation, and it has a variable response to treatment. Several other factors that are involved, as it is the metabolic health, the genetics and epigenetics, the microbiota, and of course, age, sex, ethnicity, diet, and alcohols. This is also well shown in this cartoon from Tilg and collaborator, where it is seen that the major risk factors that can result in the presence of MAFLD. And of course, each of them, in fact, predisposes for the other ones. So we have a disease that, as we have seen before, is a very frequent disease among the population. It can be present in about 1/4 of the population, although only a small proportion will progress to severe liver disease. And the problem is that those that are going to progress need to be identified, since they can progress to more advanced liver disease and cancer. And in what regards diagnosis, this is from the guidelines of the EASL, of the European Association for the Study of the Liver. And ultrasound is still the first line for the diagnosis of NAFLD. However, what we have known and have been increasingly aware in recent years is that in what regards prognosis, The most important finding is fibrosis. In fact, fibrosis is the only histological finding that has a prognostic significance. Consequently, it came to mind, and everybody realized that probably among populations it was more important to screen for liver fibrosis than to screen just for the presence of NAFLD. And to this aim, we have rather simple and inexpensive methods, such as the scores, the NAFLD fibrosis score or the FIB-4. And then we have more expensive patented tests, such as the ELF, the fibro test, and the fibrometer. These are tests that can be done in blood. And then we have a machine that has recently become very popular. That's the FibroScan. And a FibroScan is probably not so expensive, at least in some countries, and it's probably the more reliable of all these tests. So there is this algorithm for the non-invasive assessment where we can start by ruling out those that are at low risk of progression and at low risk of fibrosis by having a low NAFLD fibrosis score or a low FIB-4. And so in these patients, we would only consider repeating the tests every 2 years. Or we can have individuals that are in the intermediate or gray zone of the values of the scores, and those correspond to about 30%. They are at intermediate risk, and in those we could apply either these more expensive patented tests, or we can use elastography as an imaging method. And finally, we have 12 to 15% that have very high scores and eventually also very high FibroScan. And in those, we should consider doing a liver biopsy, mostly if we are considering including them on clinical trials. So I will now move on to treatment since my time is quite short. In fact, we have already a very effective treatment that is lifestyle interventions to reduce weight. And by doing this, in the 10% of patients that are able to achieve the weight loss, we can see that there is a very significant improvement in all the factors regarding either NASH resolution or decrease in the fibrosis regression or improvement in steatosis. However, the majority of the patients, it is 70%, can only achieve 5% or less of body weight loss. And with this, the NASH resolution is in fact much lower, 10%, as well as fibrosis regression or steatosis improvement. And this is after a program of 52 weeks of lifestyle intervention. So we know that the mandatory part of the treatment is the diet and lifestyle changes. With a modest weight loss that we can induce all these beneficial results. And if we lose more than 77%, this is associated with histological improvement. So what do we recommend? Structured programs that aimed at lifestyle changes that should be for all patients. In what regards to pharmacotherapy, there are no firm recommendations, although pioglitazone or vitamin E can be used, but the optimal duration of therapy is unknown. So at the present moment, there are no medications approved by the FDA or the EMA for the treatment of NAFLD and NASH, and any drug treatment is off-label. So what new drugs and what targets do we have? We have several different targets that can act in the different phases of the progression of the disease. Here we have a list of all the drugs or the mechanisms through which drugs can be used to try to prevent the progression from the normal liver to NAFL, NASH, and cirrhosis. And here I show you the main four class of drugs, obeticholic acid, elafibranor, selonsertib, and sencriviroc, that have been in phase 3 studies. However, so far, we have seen that either elafibranor and selonsertib had unfavorable preliminary results. On the opposite, the preliminary results from obeticholic acid are favorable, although not with a very large margin, but the results are in fact positive. And we are still waiting for the results from Aurora and from Tandem. Given these bad results of these clinical trials, innovative clinical trials have to be considered. And considering the substantial heterogeneity of the patients with MAFLD and the limited response to investigational targets, trial designs should be a little bit different. They should be either umbrella trials, where using different biomarkers, we could choose to have different lines of treatment, or then basket trials or adaptive design trials to try to make them more related to the particular patients we are treating. There are also possibility of new molecules like Carbolife, that are some oral non-nanoporous carbon therapy that has been shown a considerable promise to diminish disease pathogenesis in NASH, and a clinical trial is about to start very soon. Just to give you a brief word about patients with NAFLD and COVID, there is this recent paper from G and collaborators where they have shown that patients with NAFLD have a high risk of progression to severe forms of NAFLD. And this is according to this study, where, as you can see, those that had progressive forms in a very high percentage had NAFLD. And the discussion has come to the fact there's no evidence for an increased liver uptake of SARS-CoV-2 in metabolic associated fatty liver disease. So probably the mechanism is through the dysregulated hepatic innate immunity in NAFLD that would predispose for more severe forms of COVID. So my take-home message is that we are not, in fact, at the present moment, having availability of effective drugs. But even if the very effective drugs will be confirmed, it will be difficult to define treatment timeline, since it will tend to recur if the risk factors remain. And so the more important, in my perspective, is the political measures that will be able to revert the epidemics of obesity. And so EASL has issued some position papers just trying to give the recommendation for the public health measures, mostly that include the reduction of industrially processed foods, the fiscal measures to discourage the consumption of the sugar beverages, health education programs, policies and changes to local infrastructures, and the expansion of the public health knowledge about NAFLD, and also, of course, the funding of new diagnostic research programs. Thank you very much, and I will be now open for questions. Thank you.
Thank you very much to Professor Helena Cortes Pinto from Portugal. We will have time for questions a little bit later. So, HCC in NASH is title of presentation of Professor Elisabetta Bugianesi. Professor Bugianesi is Scientific Director of Department of Medical Sciences at University of Torino. Welcome, Professor Bugianesi.
Good afternoon, everyone. The topic of my presentation today is about hepatocellular carcinoma and NASH. The risk for hepatocellular carcinoma in people with NAFLD starts at the stage of non-alcoholic steatohepatitis, particular non-alcoholic steatohepatitis with fibrosis, and of course, it greatly increases in NASH cirrhosis. The annual incidence of hepatocellular carcinoma in NASH ranges between 2.4 and 12.8%, which is lower compared to hepatitis C, but you have to consider the much larger burden of patients with NASH compared to hepatitis C. So it is not surprising that non-alcoholic steatohepatitis is the most rapidly growing indication for liver transplantation in patients with HCC in the United States. Here you see that the first cause of hepatocellular carcinoma is still hepatitis C, but the second cause, and the one with the steepest increase, is NASH. And to make things even more complicated, we know that hepatocellular carcinoma can also arise in patients without cirrhosis, as demonstrated in these large studies here among 14,000 patients with HCC. Among the NAFLD HCC patients, 38% had no cirrhosis. And this has been further confirmed also in several other studies. So 40% is approximately the percentage of patients with HCC and without cirrhosis in NASH. This is because there are multiple risk factors for HCC beyond the liver disease and cirrhosis itself. There is the independent contribution of the metabolic syndrome, and in particular of obesity and type 2 diabetes. There are genetic risk factors, and maybe there is a role of inflammatory adenoma, the one that can arise in people with obesity and metabolic syndrome. Who can have an increased risk of HCC in NASH? Usually these patients are mainly white, male, obese, significantly older than patients with HCC of other origin, with an increased prevalence of diabetes and increased cardiovascular mortality. If you look at the relative risk of HCC, which is carried by the components of the metabolic syndrome, you see that obesity, independent of other factors, can increase the risk of HCC by 2.5-fold compared to non-obese, and type 2 diabetes by 3-fold compared to non-diabetics. And the risk of HCC increases in parallel with a number of the features of the metabolic syndrome, so patients who are overweight and diabetics has a risk which is 4.75 times higher compared to non-obese and non-diabetics. This risk is greatly increased if obesity starts during childhood, and this is what it has been demonstrated in this study, where they followed a cohort of almost 300,000 Copenhagen school children aged 7 to 13 for 30 years, and they were able to see that childhood obesity increased the risk of HCC 30 years later, and it was an increase that was related to BMI itself. There are also a number of genetic variants that can increase the risk of HCC in NAFLD. We know the PNPLA3, TM6SF2, and the MVO87 variant. All these variants can increase the risk independent of age, sex, obesity, diabetes, and severe fibrosis. And if you have more than one of these variants, then the likelihood of having HCC increases proportionally. So, compared to the standard risk, which is the risk of people with NASH and NASH cirrhosis, there are other additional risk factors that can increase the risk or accelerate the progression and the onset of hepatocellular carcinoma, for example, childhood obesity, genetic variants, the sum of the two, and there are other superimposed hits, such, for example, alcohol use or abuse, viral infection, and adenoma, that can hasten this progression in unpredictable way. Now, surveillance is a problem in this patient. We know by guideline that surveillance is recommended in specific target population, in particular cirrhotic, but also non-cirrhotic F3 patient, but based on individual risk assessment. However, the role of surveillance for patients with NAFLD without cirrhosis is unclear, and most of all, the diagnosis in this patient should be established by liver biopsy. Now, poor surveillance is a constant problem for NAFLD patients. Just 23% of patients with NAFLD have their HCC detected by surveillance, and this leads to a decreased overall surveillance. In this SARE database, where NAFLD represented 1/4 of the etiology of HCC, you see that compared with HCV and HBV, the survival of patients with NAFLD was lower, and factors associated independently with 1 year mortality were older age and stage tumor and the presence and etiology related to NAFLD itself. And so the European guideline says that the large number of NAFLD cases at risk of HCC makes systematic surveillance largely impracticable. We know that PNPLA3 gene polymorphism might provide patient risk stratification, but it is not yet considered cost-effective. So their recommendation, their conclusion is that although NAFLD is a risk factor for HCC, which may also develop in the pre-cirrhotic stage, and the risk is further increased by the presence of the PNPLA3 CG polymorphism, no recommendation can be currently made on the timing of surveillance and its cost effectiveness. So the first thing that should be implemented is stratification of people at high risk, that is, people with NASH and particularly those with fibrosis. Risk stratification should start at primary care referral. And this is the Camden and Islington NAFLD pathway that has been tested in UK. All general practitioners who were involved in this study stratified the risk of fibrosis in this patient according to FIB4 into low risk, those with result lower than 1.3, at high risk, those with a FIB4 higher than 3.25, and those with a high risk were referred to a pathologist. There was a gray area, that is, people falling between these two thresholds. These people, these patients, were tested again by ELF and again re-stratified and reassigned either to low or high risk category. And this is very important because this is primary preventive intervention. In fact, we have several steps where we can do prevention. Stratification, but also lifestyle intervention is very, very important because it prevents the development of steatohepatitis and the progression of steatohepatitis to cirrhosis. We also have a lot of drugs that are under development, in particular the obeticholic acid seems to be very promising. And there are a lot of other therapy, either anti-inflammatory, anti-fibrotic, or again against the metabolic disease that are associated with NAFLD that can help us to prevent the development of hepatocellular carcinoma. There are some meta-analyses that suggest that the use of metformin has been linked to antineoplastic effects, and also statins may decrease the risk of cancer, and this has been demonstrated in a meta-analysis of 26 randomized trials where the use of statins was associated with a 37% reduction in the incidence of HCC. However, there is no current evidence to suggest they are used to prevent HCC, but we should continue metformin and statin in cirrhosis, at least to decrease this risk. So in conclusion, hepatocellular carcinoma associated with NAFLD is rising markedly. Obesity and type 2 diabetes are independent risk factors for HCC development. HCC in NAFLD generally rise in cirrhotic liver but can also occur in patients without cirrhosis. Robust epidemiological data about prevalence and incidence of HCC are still unavailable. We need those data. And also we need early diagnostic biomarkers for identifying NASH and HCC. In the meanwhile, we should promote lifestyle change in the general population, and most of all, prevention of obesity from childhood should be a priority in the agenda of educational programs. And I thank you so much for your attention.
Thank you very much to Professor Elisabetta Bugianesi. After Italy, we came back to Croatia. Our next speaker is Professor Tajana Filipec-Kanizhej. Professor Kanizhej is head of Department of Gastroenterology, University Hospital Merkur, and the topic is NASH-related outcomes in transplanted patients.
Thank you. I would like to thank the organizer for kind invitation and start with the talk about the outcomes of liver transplantation in the field of non-NAFLD. As we all know, the real impact closely mirrors the global epidemic of components of metabolic syndrome also in peri-transplant period. We don't know the real incidence and prevalence of the disease because most of our patients have overlap of NAFLD, which is diagnosis of exclusion, with other diagnoses, for example, alcoholic liver disease and many others. But as far as we know, that this is the growing indication for transplantation. It's on the second or third place in the United States and represents around 10% of indications in European Union. We can see on those slides that this is highest growing indication on the field of cirrhosis or its complication in United States, but also in European Union, but also in the field of hepatocellular carcinoma. From our center, which is the biggest center for adult liver transplantation, we can see that the most growing indication in the field of all diagnosis is HCC. And on the right part of the slide, we can see that in the field of HCV infection, I don't know if this pointer is working, but also, here it is working. We can see that the rate of patients transplanted for HCV infection with HCC is still growing, representing almost 70% of all HCV positive patients transplanted in our center because of HCC. 42% of patients transplanted for NAFLD are now having HCC, and 30% of all alcoholic liver diseases are transplanted because of HCC. So HCC is 1/3 of all transplant patients in our center, and in the last 10 years, 12% of all transplanted patients because of HCC have NAFLD as baseline diagnosis. Those patients which are liver transplant candidates also at a high risk of cardiovascular comorbidities, and almost this risk is almost 3 times higher than in overall cirrhotic population. In post-transplant period, this does not influence the outcome of recipients and grafts, and there is a question whether this is pre-selection, pre-transplant bias, because most of our patients with NAFLD are dying on waiting list because of cardiovascular comorbidity. On long term, those patients have more cardiovascular events in post-transplant period, almost 3 times higher risk of fatal cardiovascular events than overall transplanted population, almost 2 times high risk of infections and sepsis, high risk of kidney disease, all kinds of malignancy, and the impact of HCC as an indication for transplantation and the risk of recurrence is not different compared to other HCC indications. Of course, the effects of metabolic syndrome and obesity also has impact on the characteristics of our donors, and we can see that almost 1/3 of our donors have steatosis or are obese. And we are managing mostly with steatotic livers in our transplant center also. What is the course of the NAFLD after transplantation? It depends on correct diagnosis and identifying of pre-existing liver disease. And most of the data that we have on this time are from studies that are based on small number of patients, different diagnostic methods, and short follow-up time. So we need more studies in order to accomplish the data about real course of NAFLD after transplantation. Many diagnostic methods that we are using, and mostly are related to non-invasive ones, in liver transplant setting are not so accurate. This relates to FibroScan, which is not very well validated in post-transplant setting, but also on laboratory methods based on thrombocytes, because we know that level of thrombocytes are influenced by many factors and not closely correlated with the level of portal hypertension after transplantation. Steatosis is common after transplantation in our biopsies, whether this is the donor steatosis that were implanted in livers, whether this is the steatosis related to NAFLD, whether it is related with different drugs that we are using in post-transplant period. But what we have regarding the cause of NAFLD after transplantation now, we think that there are two different scenarios. One is the recurrence of the disease in patients transplanted due to NAFLD, and the one other disease is de novo disease in patients transplanted due to other causes. And we cannot distinguish those entities based on histological features, but we think that recurrent disease may present earlier, more frequently, and may progress more rapidly than de novo disease. We can see then advanced fibrosis is occurring in up to 10% at 10 years in post-transplant period, and only half of these numbers in de novo scenario. According to data from our center, this is retrospective analysis of biopsies we have performed in more than 6 months after transplantation. We can see that the stable disease, no steatosis or stable steatosis from implanted steatosis in donors, is present in most of our patients, and the patients ranging from 6 months to 5 years after transplantation have recurrence of NAFLD in almost 24% of our recipients, and de novo in around 12.4% of our patients. Regression of bioptic finding of components of NAFLD is present in 1/3 of patients with de novo disease, with interventions in components of metabolic syndrome mostly, and only 5% of patients that experience the recurrence of the disease. Regarding risk factors, they are very similar like in general population, mostly in post-transplant period related to the obesity and weight gain, which is occurring in 1/3 of our recipients. But there are also some specific risk factors like immunosuppression, mostly related to the effects of tacrolimus on the risk of diabetes mellitus. But also there is increasing data of many other factors associated with NAFLD in general populations like microbiome and many other factors. Regarding the course of the NAFLD after transplantation, we know from our data that risk of and components of metabolic syndrome are very prevalent even in our population. This is our general transplanted patient population. We can see that 1/3 of them have diabetes, 1/2 of them arterial hypertension, dyslipidemia, and the population of patients that have progression of NAFLD have more prevalent components of metabolic syndrome than the population with the regression of metabolic components in biopsies of our transplanted patients in follow-up of more than 1 year after transplantation. I would like to conclude that NAFLD and their complications are the most rapidly growing indication for liver transplantation. This is multifaceted disease. It is very important to optimally select patients and condition them for transplantation in order to retain the comparable graft and recipient survival in post-transplant period. it is important to maintain components and influence on components of metabolic syndrome in peri-transplant, in post-transplant period. And of course, we need further studies in order to see the outcome of our disease, and of course to validate diagnostic and therapeutic intervention in transplant population. Thank you.
Thank you very much to Professor Tajana Filipec-Kranjic. Sorry. Our last speaker came from the same team, from the same hospital. She is a member and specialist at the Department of Gastroenterology, University Hospital Merkur, and the topic is best pathways for therapy referral clinical practice. Jesam rekla ime Ivana Mikolašević.
For the first, I would like to thank to Tatjana for this kind invitation and for this excellent organization. So I will talk about non-alcoholic fatty liver disease in our clinical practice. So is this working? So with the help of family medicine doctors, endocrinologists, and nephrologists, we have started with the NAFLD project, actually with the NAFLD clinic at the Department of Gastroenterology, University Hospital Center Rijeka in 2012. And at the Department of Gastroenterology, University Hospital Merkur last year. And our NAFLD team consists of doctors that are mainly gastroenterologists and nurses that are dedicated to our NAFLD patients. Family medicine doctors, nephrologists, and endocrinologists refer patients with one or more components of the metabolic syndrome to our NAFLD clinic, and all that patients are screened for fatty liver disease. And since 2012, we have carried out screening on more than 10,000 patients, and more than 6,000 patients had fatty liver disease, and more than 5,000 patients are prospectively checking in our NAFLD clinic. So we have suspected fatty liver disease in patients with one or more metabolic syndrome components, in those with normal or abnormal liver findings, in those with a bright liver as seen on the US, and based on FibroScan with CAP findings, and of course other liver diseases were excluded. And since 2012, a liver biopsy was done in more than 400 patients. And based on our results, we have published more than 60 publications in CC journals and more than 35 publications in other journals. So in our NAFLD clinic, a comprehensive clinical assessment is carrying out in each patient, and together with the evaluation of metabolic risk factors. So for the evaluation of obesity, we are doing anthropometric measurements. Also, in all patients, evaluation of hypertension is carrying out. Furthermore, in all patients, an extensive blood checking is carrying out, including all of this. And finally, ultrasound and FibroScan VCAP is carrying out in all patients. And of course, in high-risk patients, screening for HCC is carrying out. Furthermore, regarding the fact that non-alcoholic fatty liver disease is actually a multi-system disease, evaluation for cardiovascular diseases and evaluation for chronic kidney disease is carrying out in all our non-alcoholic fatty liver disease patients. Furthermore, in a part of our fatty liver disease patients, nutrition consulting is done by our dedicated nurse. And finally, we are checking and evaluating all procedures that were done for each NAFLD patients. At the end, patients are checking prospectively, of course, depending on the initial findings, and our dedicated nurse take care about that. Furthermore, in order to increase awareness about fatty liver disease, we have organized together with Hepatos a public health action last year in city Rijeka during NASH Day. Also, we have wrote a booklet about fatty liver disease for patients. And finally, we have created, actually, we have opened a Facebook and Twitter page under the name of NAFLD Croatia, also to increase the awareness about this chronic liver disease. And finally, thank you for your attention.
Thank you to our last presenter, Ivana Miklošević. Ladies and gentlemen, that's all, folks.